Welcome to Classification and Assessment of Abnormal Behavior, Part 1, the History of Diagnosis and the DSM. Classification is defined as the process that we engage in constructing groups or categories and then assigning objects or people to those categories on the basis of shared attributes or characteristics. In abnormal psychology, we need classification systems because we need to be able to communicate with one another, and we need to be able to make predictions about how one's condition will fare. Communication. If we had no way of ordering and labeling disorders similarly, scientists would have a difficult time communicating with one another about our knowledge and our practices and our findings. And this would stymie our science and stymie the progression of the field. For example, if in England they called schizophrenia hallucination disorder, but here in the States we called it schizophrenia, it would be hard for us to be sure that we were communicating at all, let alone communicating about the same content. Also, if people in England had a separate set of criteria for what would count for hallucination disorder than we had for schizophrenia, we would not even be talking about the same thing anymore. We also need to be able to make predictions. When we know someone's psychological profile, we can compare it to previous cases and gather valuable information on their prognosis, what treatments might work, and the etiology. What is prognosis? Well, prognosis helps us understand how a person is likely to fare with the course of the disorder. Things like how long will recovery take, whether the disorder will remit on its own or require treatment. Is it something that once it starts, it should last continuously for decades, or will it end relatively quickly? Or is it something where people get better and then worse again, better and then worse again over time? Treatment. What treatments are likely to actually help for this particular condition? And etiology, remember going back to the beginning, etiology is the cause of a condition. Well, once we know what conditions are and we make predictions, we can also look backwards, and it will help us make predictions about the underlying causes of the particular condition or disorder. DSM stands for the Diagnostic and Statistical Manual of Mental Disorders, and we're currently on our 5th edition. This is the current system for classifying psychological disorders used in the United States. It's used by both clinicians and researchers, and it helps professionals make diagnoses, ensure that the diagnoses that are made are accurate. You should know that this is published by the APA, but not the American Psychological Association that we have in psychology, but instead the American Psychiatric Association. And this has the potential to become important down the road when we talk about the way that this document has been put together, what it means, how it's used, and how it's codified. We're going to go through some of the changes that happened with the DSM over time. Even though we are on the 5th version currently, there are 7 versions total. The first version was back in 1952, which I realize that's 70 years ago. But if you think about the history of psychology, it's really not that long ago. The idea that it was only in 1952 that they decided to put together a guidebook to help clinicians be accurate and consistent in diagnosis. And again, the current version is the DSM-5 that was published in 2013. Before we talk about the current version of the DSM, let's take a walk backwards in time and talk about the development of the DSM to the document that it's now become. Once again, the first version of the DSM was back in 1952, and in the beginning it was just paragraphs giving clinical descriptions. They did not have any specific criteria related to specific disorders. This made diagnosis very unreliable, and different clinicians would interpret the exact same information in paragraph very differently from one another. And although this first document was so problematic, it took 16 years for them to come up with another DSM that hopefully was going to do a little bit better. Again, this version was still pretty problematic because it only gave a clinical description. It didn't give clinicians any formal criteria to work on. Around this time, it also became known that schizophrenia, for some reason, was much more common in the United States. but mood disorders with psychotic features were more common in Great Britain. Well, it doesn't really make any sense that these disorders would have vastly different prevalence rates from the US to Great Britain. Various studies were done to better understand why these differences existed. And they determined that the system used by the United States, the DSM C Criteria, were too broad when looking at schizophrenia. And then the ICD, which is used through most of the world, had criteria for mood disorders that were too broad. So clinicians were interpreting these symptoms, even though they were seeing the same symptoms, they were interpreting them very differently. Because of the many questions regarding the DSM's reliability, some studies tried to determine how clinicians were actually using the DSM in order to figure out how it was so unreliable and inconsistent. The goal of one study in 1962 was to determine if two experienced clinicians would reach the same diagnosis when they were evaluating the same person. All in all, they had 4 clinicians that participated, and they were allowed to read through the DSM criteria prior to giving their diagnosis. The bottom line was the agreement for diagnoses was not very good. 53% of the time, they saw the same information and diagnosed the person with schizophrenia. 54% of the time labeled it as sociopathy, and 40% of the time said that the person had depression. It goes without saying that if clinicians are looking at the exact same case, we should not see a range of disorders from schizophrenia to depression to psychopaths. We've got to do better than that. Follow-up studies tried to figure out why the classification systems were leading to them having such different diagnoses. And they determined that 5% of the time there was indeed some change in the patient that was leading to these differences. Almost 33% of the time, the problem was that clinicians were not asking the same questions, and so they were following paths that led them to particular diagnoses and then away from others. Believe it or not, the biggest problem was with the classification system itself. Clinicians, when they got the same information, the classification system did not give them what they needed in order to make sound clinical decisions. To give you a sense of what they were working with, here is a description of manic depressive illness, manic type, taken from the earlier versions of the DSM. This disorder consists exclusively of manic episodes. These episodes are characterized by excessive elation, emotionality, talkativeness, flights of ideas, and accelerated speech and motor activity. Brief periods of depression sometimes occur, but they never are true depressive episodes. What are some problems you notice with this? What are some things you might like to have clarification on if you were making a diagnosis for a real person? A couple of things I would point out. One, it's not clear, does someone have to have all of these symptoms or just a few? How long do they have to have lasted? If it lasts for an hour, is that enough? Does it have to last for a week, a month, a year? What do the depressive episodes need to look like in order to count as a depressive episode? If I'm weepy because something bad happened, would that count? What is a true depressive episode if these are never true depressive episodes? What do I need to know? On top of that, what do any of these particular symptoms look like? In real life, I'm a very talkative person and I talk very, very fast. Is that enough to count for accelerated speech and talkativeness? So looking at this, it becomes clear that we needed something new. And that led to advances in the DSM, moved us from the DSM 1 to the DSM 2, but still the changes were not significant enough to create comprehensive change in the outcomes. After nearly 30 years, the DSM 3 arrives, and this version was now a major, major change. They substantively revised the DSM altogether, developed criteria sets, where specific symptoms were identified and specified, as well as providing data on the required number of symptoms that were required in order to have a diagnosis. This was an attempt to make the DSM and diagnostic process more reliable, and it really became a prototypical classification system. But unfortunately, a variety of problems remained. The criteria that were decided on for inclusion were committee members made up exclusively of psychiatrists, not psychologists, not other mental health workers. And this is important because psychiatrists typically work with severe psychopathology that you would see within a hospital setting. These are also going to be conditions that are better treated with psychiatric medications. So they may know a lot about those disorders, but they may not know as much about other disorders that are less likely to be seen in hospitals. They also did very little research. They largely came up with the decisions for what to include and what not to include based on their own experiences and opinions about these disorders. And this brings up a problem of validity. The disorders were now more reliable, but it's not necessarily clear whether or not they are more valid or accurate. They also added 100 plus new disorders here. And again, this was done by committee, not research data. This led to them doing things like putting learning disorders into this diagnostic and statistical manual, which makes them mental disorders, but this is very controversial. Many would argue that just because something is in the DSM, it doesn't mean that it should be deemed a disorder, and it certainly doesn't mean that it is a psychological disorder. 7 years later, they come out with a new change, the DSM 3R, R for revised. But unfortunately, it wasn't much of a revision. There were some changes, but nothing major in any of the criteria. An example was bulimia nervosa in the DSM-3 did not require purging, but it did require purging by DSM-3R. That was one of the more substantive changes and was not substantial. Then in 1994, we saw the DSM-4 come about. And this was a major change. Everything changed in how the criteria were established and how they were evaluated and how it was determined what should go into the DSM and what should not. They appointed task forces to review sections of the DSM-3R. They prepared literature reviews. They analyzed previously collected data and even collected new data when necessary. This was the first time that decisions had to be made based on empirical evidence and data. Remember, in the past, it was psychiatrists making decisions based on their own personal opinions about cases they've seen. Changes always were decided on by the full committee of experts in their areas. This again is a significant change. Before the DSM, changes could be based on clinical evidence, not necessarily any empirical data. It was also the first time that the American Psychiatric Association paired with the World Health Organization. And the World Health Organization is the organization that puts together the International Classification of Diseases. Now we had both major documents that were used across the world coming together to develop the criteria sets so that the DSM and the ICD matched. The DSM-4 also added a multidimensional perspective, and we had a multi-axial system that made the clinician specify functioning on a number of different levels. So there was an overall rating of functioning. They had an axis that was specific to talking about medical problems, another one that was specific to environmental stressors. Together, this gave a more robust picture of a full client's life and current circumstances, and not merely a list of disorders. 2013 ushered in the DSM-5. One of the tiny changes here was they got rid of the Roman numerals. So now it's just DSM-5 without the Roman numeral 5. For the DSM-5, they re-evaluated all aspects of the classification system and the elements within it. They changed everything from symptoms and criteria to the actual disorders themselves, and they did this based on panels of experts who conducted research and had intensely studied the data. They also got rid of the multi-axial system that had been introduced in the DSM-4. I will say it wasn't to say that they thought the multi-axial system was not important, but what they found is there was difficulty in actually getting people to implement it properly and accurately, so it wasn't ending up doing what they needed it to do. They also added a cultural formulation, and unfortunately this is not required, but it was the first time that thinking about a cultural framework and how these disorders also interface with individuals' lived experiences and their cultural experiences. This was the first time that this was ever introduced into the DSM. I'll also add that the cultural formulation was not specific to people that were somehow culturally different. The cultural formulation could now be applied to all clients and give a rich, in-depth picture of their understanding of their condition, their social supports, how their family and community were able to respond to their symptoms and provide support. So it's applicable for everyone. The DSM is now comparable with the ICD-10. You can diagnose people with both the DSM and the ICD and have the exact same conclusions and formulations. They have a slightly different numbering system, but the diagnosed titles and conclusions are the same. Some things to think about. The DSM-5 is still heavily rooted in a medical model, which has some positives and has some negatives depending on your zeitgeist and feel about this. And it's still a categorical model of classification, where there's 20 general categories of disorders, and then you filter them down into more specific subtypes. And we'll talk down the road about the need for dimensional assessments. But the DSM-5 also begins to make room for offering dimensional assessments so that we don't have to always have things fit into a categorical model. I really can't overestimate the magnitude of the changes moving into the DSM-5. Here they added several new diagnoses, and some of these diagnoses were formerly in the DSM-4. Some of them were there as in the appendix as diagnoses for future study, but now they've moved into the formal diagnostic categories. An example of this is binge eating disorder that we'll be talking about later this semester. Some of the diagnoses that were added were completely new, like a mild neurocognitive disorder. They also changed the classification of some disorders, adding new categories such as obsessive compulsive and related disorders. Some were folded into broader categories. For example, Asperger's has now been folded into autism spectrum disorder, and some were moved into new categories altogether. For example, body dysmorphic disorder is now included under obsessive compulsive and related disorders. They also changed the criteria for some disorders. This is actually a tricky thing because once you change the criteria, you change who fits within a category, and it may begin then to change the prevalence rates for people within that category. Let's go back and revisit the criteria for a manic episode. We already read what it had looked like back in the DSM-1 and 2. Now let's see what it looks like in the DSM-5. Criteria A says we have a distinct period of abnormally and persistently elevated, expansive, or irritable mood, lasting at least 1 week, and present most of the day, nearly every day, or any duration if hospitalization is necessary. During the period of mood disturbance, they must have at least 3 out of 7 symptoms and 4 if their primary mood is irritability, and that these symptoms are present to a significant degree and represent a noticeable change from one's usual behavior. Inflated self-esteem or grandiosity, decreased need for sleep, for example, feeling rested after only having 3 hours of sleep, more talkative than usual, or a perspective of needing to keep talking because they feel pressured to keep talking. And for ease, we won't go into the next 4 other symptoms to look at, but just give you a sense of how much more detailed it is. In criterion C, a manic episode during antidepressant treatment is sufficient evidence of a manic episode. Think about how significant these changes are. So 1, it's telling you how many of the symptoms need to occur at the same time. It gives you a distinct time frame for how long they have to last, that they have to last at least a full week, but also that if it's so severe that they have to be hospitalized, then that's already more than enough to count. It talks about the findings we now have that if somebody is being treated for depression with an antidepressant, but they really have mania, that the medications will likely spark mania, and that if you see that, it's automatically enough to count as a manic episode. They also give us some context to what the symptoms should look like. So the decreased need for sleep in the past would often be confused with insomnia. So with insomnia, people often feel exhausted and they can't sleep, but they want to sleep. Here they make the clarification that these are individuals that are not getting much sleep and yet they feel completely energized. As you can see, the additional clarifications and level of detail make it far easier for clinicians to go about the process of accurately diagnosing and to make sure that they're getting that diagnosis correct. Despite the improvements of the DSM, there are still a number of criticisms related to DSM itself and the process of diagnosis. Going back to the socioculturalists, there's still grave concerns about what are the effects of labeling individuals as having mental illness. A label of being a mental patient or a schizophrenic has negative consequences. People are highly stigmatized when they're labeled as having mental illness. Research shows that the general public has very, very negative views of mental illness and those that have been hospitalized for mental illness in the United States especially. The negative view then leads to them being treated differently by friends and loved ones as coworkers, and they have a difficult time being able to get a job and retain a job and live independently. These labels can also have an effect on one's self-esteem and lead to a self-fulfilling prophecy, where if you're told, oh, well, you have schizophrenia, you might become guarded and suspicious in case somebody find out about your diagnosis. You might chronically be on edge, fearing the onset of another attack. And these kinds of behaviors can make you look like you're having a psychotic break and that affect how others start to treat you. Despite this, there is general consensus that there are benefits of engaging in a categorization of mental disorders, and that this process of diagnosis and classification of disorders has the potential to outweigh the negative consequences, at least in the domains of research, treatment, and prevention. And as a whole, we have to focus on destigmatizing mental disorders